And I would also like to thank George and everyone else who's been associated with setting up this meeting, because I do think it's a wonderful idea, and I really appreciate the fact that I was invited to come here. I'm going to talk about lab measurements, which I'll let David do the slides. I'm going to talk about lab measurements, which you may think, that's my doctor's area. Why I have to care about this. This is your area. You are the consumer. You pay for this. Okay? And I'm going to tell you, a lot of doctors don't understand the results. It's worth your while to know this stuff. You don't have to know the chemistry behind it. You need to know what's what can I get out of these lab tests that are measured all the time. And I'm also going to show you some of the mistakes that are made in measuring values related to cystinuria. And perhaps some of you have been exposed to these mistakes, these confusions. The reason I focus on this is because I get phone calls about this from people, whether they use Litholate or not, asking me, why did this happen? Why is my patient getting worse on therapy? I get that question a lot. So I want to hopefully bring out some points that I think will be obvious when you see them, that people will think about. Now, I got two names below two titles below my name. I work at a lab company. I have a conflict of interest. David kept pointing out he doesn't have a conflict of interest. I do, okay? So remember that. Whatever I tell you, I work for a lab company. All right? David, have the next slide. All right, I'm going to go over basically 7 things. List of the 7 measurements that I think are of interest and will be valuable for you to know something about. The first 3 will be fairly straightforward, and the last 4 relate basically to your therapy. Next slide. Right. We're here for Cystinuria conference. Obviously, the first thing we warn you about is measuring urine cystine. And that is done with taking a urine aliquot or a sample of urine and measuring the amount of cystine in the urine, the cystine concentration in the urine. You'd really do it for 2 reasons. The first time it's ever done is to diagnose cystinuria. Now, cystinuria is often diagnosed because you have a stone that is cystine. By definition, you now have cystinuria. But sometimes patients don't, the stone is not caught. Doctors don't know whether the patient had cystinuria. They want to see whether the, and especially in a pediatric population, they want to know, was that stone a cystine stone? So sometimes you measure the urine cystine concentration. Is it elevated? If a sibling has cystinuria, if one child has cystinuria, perhaps you want to screen your other children. Do they have cystinuria? Before waiting to see if they get a stone, you might just get a urine cystine measurement to diagnose the disease. After the disease is diagnosed, the reason cystines are measured is to monitor therapy. Are things getting better? Is the therapy working to reduce cystine concentration or change cystine solubility, as David mentioned, in a way that you would predict would prevent kidney stones? The final proof is therapy works is if you don't form kidney stones. But you'd rather have a measurement in between before waiting for another stone to find out if therapy is adequate. This is why you measure urine cystine. Cystine can be measured in a timed urine collection, usually a 24-hour urine collection, in which case you collect all your urine for a 24-hour time period. We know how much, you figure out how much urine you make, you figure how much urine is in the cystine, you can get how much is excreted. You can also measure cystine in a random sample, just a one urine void, so-called a spot or a random urine. That is done, that's not my favorite test, but it is done at times, particularly in the pediatric population where it's difficult to collect a 24-hour sample. It's particularly for diagnosis. You can relate the cystine to the creatinine in the urine and come up with a ratio that says, is this an abnormally high cystine? And certainly that is useful for a diagnosis. For treatment monitoring, personally I prefer to get a timed urine specimen, generally 24 hours, and get an idea of how much cystine you're actually excreting and how close to the solubility limit that cystine is in the urine. Urine creatinine, David mentioned creatinine. Creatinine is a waste product of muscle metabolism. David mentioned it as far as measuring it in blood. I'm going to tell you, we measure it in urine. And I will tell you there's almost no urine sample that should ever be collected in which creatinine is not measured. I don't care what the disease is. If it's not, other than looking at urines for infections and how much bacteria there is, every time a urine is done, a creatinine should be measured. Why? Because it tells us about the quality of the collection, if you will. When you do a 24-hour urine, and you excrete X amount of creatinine, let's say 1,500 milligrams of creatinine. How much creatinine you excrete is dependent on your muscle mass. How much muscle do you have? Arnold Schwarzenegger excretes a whole lot more creatinine per day than I do, all right? But my muscle mass isn't likely to change from now to next month. And if I do a collection today and excrete 1,500 milligrams, next month, if I do the collection the same way, I should excrete 1,500 milligrams again. If I mess up and do either over-collect or under-collect, it'll be reflected in that creatinine excretion rate. So if your doctor says to you, when you come in, and he says, you didn't do a full collection, he's just not guessing, all right? Or she's not guessing. The first time you did the collection, you had 2,000 milligrams of creatinine. The next time you did 1,000 milligrams of creatinine. The two collections are different. If you over or under collect your urine, it'll change how much cystine appears to be in your urine. This is your quality control of the urine. I do 24-hour urine collections all the time. I'm not a stone former. I do it just for research. I am the normal in the Litholink database. Okay? 1,000 urines have been collected for me. But I know as I collect, every once in a while I go, did I go in the jug or did I go in the toilet? I can't remember. People make mistakes. It just happens. So the creatinine is our quality control. We kind of guess. It gives us an insight into, was this a good collection, bad collection? I'll have to adjust it in my mind. It looks like they've lost about 20% of the urine. And that's how we know. And so when your doctor says, yeah, it wasn't such a great collection, they're comparing it to your prior work. You know, you've had 5 other urines, and every time you got 2,000 milligrams of creatinine. If you come in with 3,000 milligrams of creatinine the next time, something went wrong. Okay? So it's a quality control, and that's why we measure it. And finally, your volume. When you do a timed collection, we're always interested in how much urine did you make. One reason is if we don't know the volume of your urine, we can't calculate your cystine excretion rate. We can know the cystine concentration, what's the concentration in the urine, but we have to know how much urine you make to know how much cystine you excrete. In addition, the volume is obviously one of your major therapeutic outcomes. Do you make 2 liters of urine a day, which Dr. Goldfarb told you was inadequate? Do you make 4 liters of urine a day, in which case everyone's pretty happy? So we're very interested in the urine volume because it is very important as an aspect of your therapy. All right. I want to talk about some of the problems with cystine measurements. You would think that cystine has been measured for 100 years. We'd have it right by now. But measurement of cystine has a ton of problems. Now, you probably recognize this stuff. Cystine crystals in the urine. What do we think about this? This is from a patient. Cystine patients often crystallize cystine in the urine. When that cystine crystallizes, it falls to the bottom of the collection container. When it's not in solution, it is no longer measured. What does that mean? It means if this happens during a collection, the amount of cystine that patient has will be underestimated. You and your doctor will be fooled about how severe your cystine excretion problem is. Next slide.